All right. Now I'm going to turn things over to Dr. Swan Adams.
Hello, everyone. It is so fabulous to see all these faces and to feel like I'm in the sandbox with all my friends and meeting new friends. So I'm excited about these next couple of sessions because this is kind of our highlight here. Here are our colleagues who are delving into this world, and they've begun their projects, and so we're going to be hearing updates. So allow me to introduce my colleagues. So first of all, I am Dr. Swan Adams, and I'm a professor in the Arnold School of Public Health and the College of Nursing here at the University of South Carolina. I am also co-lead of the analysis core of the CADMR, and I, as I mentioned, am going to be moderating this next session. So our first guest is Dr. Dace Brown. Now, I have to admit, when I know it's Candace Brown, and so when I saw on my little script it said Dace, I was like, this cannot be right. I want to make sure I'm not calling her something that's not right. So I looked her up, and she has the Dace Lab, and I was like, I love this. So I knew I could do this. So Dr. Brown is an assistant professor of gerontology in the Department of Public Health Sciences at the University of North Carolina, near us in Charlotte. So she holds an affiliate appointment in the gerontology program and the Department of Sociology at UNCC, and is a collaborative researcher with the Motivated Cognition and Aging Brain Lab at Duke University. Her research passion is to examine motivation to exercise across the lifespan. Now, our second guest is Dr. Eduardo Cabrero Castro. He is a postdoctoral fellow at the University of Texas Medical Branch in the Department of Nutrition, Metabolism, and Rehabilitation Sciences and the Seeley Center on Aging. Dr. Cabrero has served as head of the Health Economics Division, Deputy Director of Patient Safety, and Deputy Director of Childhood Cancer at the Ministry of Health of Mexico. Currently, Dr. Cabrero is conducting projects related to ADRD and health services utilization. Both of our speakers are scholars from last year's Alzheimer's Disease Registry workshop for scholars of color, and they will be presenting their research that they have conducted using Alzheimer's Disease Registry data. So please join me in welcoming our speakers.
Thank you, Dr. Adams. Hi, everyone. My name is Dr. Candace Brown, and I'm going to be presenting to you today work on death certificate reports of persons with Alzheimer's disease. I'm going to make sure that my screen can be shared, and then we will get started. All right. So, like I said, I'm going to be talking to you about death certificate reports on Alzheimer's disease, people with Alzheimer's disease. I'd like to acknowledge and thank Dr. Miller, Dr. Lohman, Dr. Pan, and Xining, who were really, really important in helping me to finish this work. So as you all know, we have over 6 million Americans that are living with Alzheimer's disease, and it's hypothesized that this number is going to increase by twofold by 2060. When we think about that, we also have to think about the fact that we are going to have a twofold number of people who are going to be dying also. And so we have to understand their cause of death, and this is imperative in understanding it. The last official death count recorded in 2019 accounted for 121,499 deaths linked to Alzheimer's disease, making it the sixth leading cause of death in the United States and the fifth leading cause of death among people who are 65 and older. Effects of early life conditions, including pneumonia and cardiovascular disease, have been reported as a cause of death in patients with Alzheimer's disease. And even though there's an increase of incidence of the disease itself, using vital statistics data to investigate how deaths are reported may assist in learning if and how comorbidities serve as underlying impacts to Alzheimer's disease itself. Heart disease continues to be the leading cause of death in the United States. And in South Carolina, the burden of it being the cause of death, the leading cause of death among Black and African Americans is something that is very prevalent. And I just want to pause for a minute and just kind of explain why we use Black and African American people in describing these ethnicities. We understand that the African diaspora in our world is very vast, and there are a lot of people who identify as being Black, but they might not identify as being African American. And so we have a lot of people, of course, in the United States who are African American, but we also have people who are only Black and they don't identify as African American, which is why we choose to put both of these down in understanding the race and ethnicities of people. When we look at the modifiable risk factors in people like cardiovascular disease, for example, these things could be something that could influence the impact of Alzheimer's disease, as we understand that reports have come out stating that the diagnosis itself might happen 20 years after the symptoms have arisen. And understanding ultimately like these related factors and how they could negatively impact the reports on death certificates is part of the reason why we chose to do this research. Reporting has changed over the past few decades, but concerns persist over the accuracy of death certificate completion. So our aim was to learn the variations in the causes of death that is reported on death certificates by coroners, by level of pre-diagnosis of Alzheimer's disease, and understanding what those modifiable risk factors are, like heart disease and diabetes. What we did is we used data from, of course, the South Carolina Alzheimer's Disease Registry. We chose the years 2014 to 2019, mainly because we wanted to make sure that we we could have used 2020, but we didn't want COVID-19 to be a factor in looking at that data. And if you heard Dr. Miller talk about earlier, some of the research that we could do later, this is one of the things that we're considering, is looking at death certificates between 2020 and 2022 in understanding how COVID-19 may have affected Alzheimer's disease and the death certificates of those people who had Alzheimer's disease. So what we did is we just looked for 2014 through 2019. And then we also got the vital statistics from the South Carolina Department of Health and Environmental Control. We used ICD-10.com to verify the death codes. And that basically is a free reference website. And what it's designed to do is to give you a fast lookup of all of the current American ICD codes that are used, like in medical billing codes and stuff like that. We did a descriptive analysis to characterize the decedents, and we wanted to compare the causes of death by race. And then we also did a survival analysis to describe the top comorbid deaths, causes of death following dementia-related causes. In our results, we found that there were 78,568 people that had been diagnosed with Alzheimer's disease in the state of South Carolina between the years of 2014 to 2019, and over 76,000 of those people were ages 60 and above, with our largest number of deaths being between the ages of 86 to 95, and the second largest number being the ages of 76 to 85. Of those 78,000 people, Black African-American people accounted for 22% of total persons. That was the second greatest number of people within South Carolina after whites. We learned that 98% of the decedents did not have an autopsy performed. And this is important because the purpose of performing an autopsy, of course, is to be able to determine cause of death. And according to the Alzheimer's Association Autopsy Assistance Network, diagnosis and research are the two main reasons for doing an autopsy, especially when Alzheimer's disease has initially been diagnosed with a person. And what they say is that, the clinical and the biomedical diagnosis of Alzheimer's disease can be up to 90% accurate these days, but it can only be positively confirmed through an autopsy. And doing the autopsy, it provides information about medical history that the families can use, and it can also provide genetic information that the families could also use. And autopsy data also provides information about the prevalence of Alzheimer's disease, which then affects the amount of funding, like we can get for great programs like this, from the government for research. And so what we learned is that, we had more males and females that died of Alzheimer's disease, or that had been diagnosed with Alzheimer's disease and actually had died of Alzheimer's disease. And we also learned that most of the decedents were high school graduates or at least had earned their GED. So we had a large number of people who had some type of education. And what we know about education is that, the further in education you go, the more likely that you're going to learn more about, different aspects. And we believe that, learning more about Alzheimer's disease would be one of those things that were learned. So when we looked at the descriptive data by race and CCB1 death, this is what we found. Now, in the data, CCB1 basically means the number one reason that the coroner believed a person had died. And there were, I believe, like 8 or 9 different sections of this. So we had CCB1 to CCB8. What we're looking at here are the number one reasons. And what we did not expect was that Alzheimer's disease actually was the top reason, with unspecified dementia following. If you remember me saying, or if you saw like in the very second slide, what's been the trend is that pneumonia and cardiovascular disease, these are the reasons that have been specified for death, which has led to Alzheimer's disease being the 6th leading cause of death among people. And so we didn't expect Alzheimer's disease to actually be the number one reason for the cause of death. And we were wrong. It actually is. And so then we wanted to look at, what are the other reasons then? And so for reasons past Alzheimer's disease and unspecified dementia, 21.9% were diagnosed with some type of stroke. And that's I-64, right? And that was the largest number of people. And if you see that, 21.9% of the people had some type of stroke, and you see that there were only, there's 3, different types of people that had stroke. For Black people, stroke was the number 3 reason when we look at the comorbid reasons for cause of death. And the other thing is that unspecified dementia. So what that basically means is when the coroner went in and they were unable to determine whether or not a person died of Alzheimer's disease or something else, they would put unspecified dementia simply because, dementia itself is a syndrome that actually leads to a disease. And so we have people who might have symptoms of a certain type of dementia, but we're unaware of whether or not it was like Lewy body, or if it was Alzheimer's, or if it was like frontotemporal dementia, or if it was vascular dementia. So they put unspecified dementia there. But what we do know is that the top 2 reasons are some type of dementia, whether it was unspecified or Alzheimer's disease. What I thought was really interesting is out of all of the races, the Native American, American Indian people did not have Alzheimer's disease as their number one reason. Their number one reason actually was lung disease. And they were the only group that actually had this. When we look also at I-251, heart disease, right? Heart disease was in fact with all of the people, right? It was just at, different levels of potential impact of death, but it was there, which, also contributes to heart disease continuing to be the number one reason, cause of death overall here in the United States. Then we also did some survival plots. We wanted to kind of look at the survival rates of people who have been diagnosed with Alzheimer's disease. And we chose to analyze the top 5 causes of death recorded by the coroners under CCB1, CCB2, and CCB3. So essentially what we're looking at are the top 15 reasons for the causes of death in Alzheimer's patients. And what you're looking at here is the analysis of those who had been diagnosed with Alzheimer's disease and an unspecified dementia. And if you look at the numbers at the bottom, what you see is that there is a great drop in between the number of people who are still alive at the 5-year mark. And so we see that only about 25% of the people will survive past the 5-year mark when they have an Alzheimer's diagnosis, and also when they have an unspecified dementia. For this, the at-risk numbers were adjusted to exclude individuals who were less than 25 years of age, because we didn't want to look at people who had early onset dementia that early. And then we also took out the missing data on the people who did not have the year of diagnosis provided. When we look at hypertension and heart disease, it's basically the same thing. We have a sharp decrease in the number of people who are surviving with Alzheimer's disease and hypertension, with Alzheimer's disease and heart disease past the 5-year mark. And we basically found the same thing when we looked at congestive heart failure and those people who had a cardiac arrest and who had died. Prior to 2000, the only way to properly diagnose Alzheimer's disease was through an autopsy. And since that time, we have MRIs, we have PET scans to determine the progression of the disease. But dementia due to Alzheimer's disease has 3 criteria that we have to consider, which would be probably having it, possibly having it, which is a clinical diagnosis, and probable with pathophysiology. And those are the people who actually use biomarkers to be able to understand what it looks like to have the disease. But possible and probable are not confirmatory. And so postmortem brain studies of individuals who have had Alzheimer's disease or other dementias offer a unique opportunity for us to elucidate how these neurodegenerative disorders impact the brain. And so linking pre-mortem clinical status of having Alzheimer's disease and using biomarker characterization of dementia, and then being able to use the post-mortem autopsy findings allows both clinicians and researchers to improve diagnosis and ultimately personalize disease-modifying therapies. A low number of Black descendants that had heart attacks, but they were likely caused to the heart disease that they lived with for a long number of times. And we also learned that the outlier of the group were the Native Americans, who, even if they had Alzheimer's disease, had lung disease as their cause of death. Here are my references. And I would just like to thank the faculty of the University of South Carolina, Office of the Study of Aging, Arnold School of Public Health. I'd like to thank Quentin Cullum, who we could not do this without him, and then my mentors and my UNC Charlotte colleagues.
Wonderful, just wonderful. Thank you so much. And I owe Dr. Brown a huge apology for mispronouncing her name.
It's okay.
And I just continue to compound it. So, and having some, another person with an unusual name, I'm like, oh my gosh, Swan. Anyway. Let's take a few minutes for some questions, about 5 minutes, and then we will go to our second speaker. So do we have any questions from our audience? Looks like Brian Downer is what I'm showing on my screen.
Hi, Brian.
Gosh, this was a nice surprise. Excellent presentation, I'll say really interesting results. Do you have information in the data set on if people, when they passed away, if they were in a nursing home or if they died in the hospital or in the community?
So that data is available, but it's not something that we were looking at specifically. So I didn't ask for it.
Okay.
I didn't ask for it.
Okay. I was just curious because I think I've seen some papers using I guess, older data that have shown like that, like cause of death with Alzheimer's disease, it was higher in nursing home settings compared to older adults who pass away like in the hospital. And so yeah, I would be curious to see if that kind of holds with more current data, especially since you were seeing interesting results with the with Alzheimer's disease being that most common documented cause of death.
Yeah, and it would be, and I don't know if there would be a difference in between, I guess like the survival analysis of people who died, in a nursing home as opposed to, being in their own home. I would guess based on, the social science that's out there that people who are living in their homes would probably have a longer survival rate. But that's a very good question. And I think something that would be interesting to learn.
Great, thank you. Great work.
Thanks. Good seeing you.
I have a question. So Dr. Brown, in thinking about your slide where you had the top causes of death and 1 and 2 being, or Alzheimer's disease and dementia for the majority of the races, and then Native Americans having a slightly different ordering. But I thought that the third cause of death kind of area was really fascinating, that you had in one group it was classified as lung disease as the third, but in other groups it was pneumonia. And I don't know if you happen to know kind of the nuances of lung disease versus pneumonia specifically.
So I don't, but what I do think, and this was something that both Dr. Miller and Lohman, what we wanted to do was we wanted to get the smoking rates of people, and it was something that we weren't able to obtain from South Carolina. But I do think that if we understood more about the smoking rates of the people, that might be a direct line to understanding also the lung disease. So you're talking about the lung disease being the top reason for Native American Indian people, and it was the third reason among whites. And so those were the only two groups that actually had it. And so I don't know, as far as like the top 5 reasons, what could contribute to that. And I mean, naturally, the first thing I think is smoking, which is why we wanted to look at that, but we never got the data. So, and we couldn't wait around forever. We got things to do. So hopefully, at some point we can look at that further, but that would be interesting. And as far as pneumonia is concerned, I think that's interesting also, because pneumonia was only found in Asians. It wasn't with any other group whatsoever. And so I don't know why that would be the case for Asians, especially since they also did not have the lung disease diagnosis as one of the top 5 reasons. So no clue.
Yeah, further research. Fascinating. All right. And I overlooked, as the moderator, I should have been monitoring the chat. So we have a question from Kim Flicker that says, what do you see in the data if they were long living in those states? Like, why did Native Americans have higher lung disease, or why did African and Black Americans have such higher heart issues?
All right. So it goes, so as far as the lung disease goes, I think that has to do with probably the smoking rates. There's a large number of people who are in Native American, American Indian that smoke. And that's not any different than, of course, what we saw with the white population also. But when we also consider the differences in those comorbidities for those populations, it's going to, I think some of it has to do with what the coroners see and what they believe, especially if they're not doing an autopsy. They might just be going off of, the social cues that they get, or what they learn from the different reports that they get from doctors. And so if they see that there's a diagnosis of lung disease, then maybe they're just like, well, they were a smoker, I can, and so I'm just going to put that there without even doing the autopsy. So one of the things that we had talked about doing is looking strictly only at the people who had autopsies to find out what were their top reasons for death. And hopefully we would have, people from, from those different ethnicities to be able to determine, is there something that's being done differently among people who are Black as opposed to dying who are white as opposed, and so that might just be a coroner thing. So the other thing is, well, maybe we should do some research on the coroners and just ask them, like, how are you making this determination without actually opening up and seeing that they have Black lungs?
All right, excellent, excellent. So thank you so much. I'm going to move to our next speaker now, Dr. Cabrero, if you want to take it away.
Yeah, thank you. I'm gonna share my screen first.
Looks good.
Yeah, okay, thank you. It was a very nice presentation, Candace. I think we complement our projects very well. We are going also to talk about here mortality and but kind of analyzed in a different way, but all of your data is consistent with mine, which make me feel a little bit more confident of my data. So my project, the name of my project is Hospitalization Trajectories After the Onset of Dementia. This is just very early results. I got the data set 2 weeks ago. So this is a work of 2 weeks, but I have to be very thankful with Maggie that was all the time with me working to get the IRB approval at my university and also getting the data set from the RFA at South Carolina. So also Brian that was commenting in the past presentation, he's my mentor here at UTMB. So also thanks to him. And okay, we'll start. So the objective here was to estimate the probabilities of hospitalization, hospital discharge, and mortality, and some factors associated with it, but not in a conventional way, more using a longitudinal model to model life trajectories. So model how people are going through different stages since they are diagnosed, how they are hospitalized, how they get discharged, what are their comorbidities, what are their sociodemographic characteristics, and all of these stratified by a race, different dementia types, specifically Alzheimer's, vascular, mixed, and others, because also there are very, very low prevalence of other specific types of dementia. So just the main ones to keep the numbers big enough for statistical significance. And I'm gonna talk a little bit more about what we tried to do here. So the thing here was to do a follow-up of people that don't have dementia at some point, right? So let's say 60 years old, they don't have dementia. Then at 61, they get diagnosed. Some of them still don't have dementia, and some of them die. What happens here? So it happens that we have transitions to different states: the state of not having dementia, the state of having dementia, and the state of being dead. And each transition is associated with rates. Those are observed transition rates. And also, since these are states, now you have occupation probabilities. So with these measures, you can construct multi-state life table analysis and at the end have life expectancies. But you can also have other outputs that are also very interesting in your way to calculating a life expectancy. So that's what we did. We followed the population over time with these observed transitions between these different states. And then we model it's a predictive model where you have a synthetic cohort of 60 people with 64 years without dementia, but they start getting diagnosed at 65. Some of them, as I told you, can stay without dementia. So you will have probabilities of having dementia at 65, probabilities of not having, probabilities of dying, also probabilities of being hospitalized, probabilities of being discharged. And that happens at each age. So you have probabilities at 65, 66, 67, and then you end 75 with the same condition of not having dementia at 64, where your probabilities of dementia, no dementia, death, and that's how you model a life history for the cohort. So our sources was the Alzheimer's disease registry with the mortality data from the Department of Health and Environmental Control, and with the hospital data of the DOC, and everything was linked by the Revenue and Fiscal Affairs Office, and we got a de-identified data set with all these variables, including comorbidities, diagnosis, admission sources, discharge destinations, and way more things. So it was a bit challenging to kind of clean it in time and do the analysis fast. But so we got the records of all events. Events are the hospitalizations of all individuals that were diagnosed between 2005 and 2019. So our initial point is being diagnosed. That is our inclusion criteria in this period of time. We got all their history of hospitalizations, having a sample of more than 1 million events. But we only wanted the events that happened after being diagnosed. We were not interested of analyzing hospitalizations that happened before being diagnosed with dementia. So that was roughly 500,000 hospitalizations that we had to drop from the sample. And also the people that were diagnosed between 65 and 100 years old, to exclude, like you also did, Candace, very young people and also very old people. And also there are some there can be some bias in the age, in how they record it. So there were some kind of outliers were not very logical. So this looked good, and at the end we had 156,000 unique individuals with 458,000 hospitalizations. This is the first descriptive characteristics of the individuals by dementia type. Most of them having Alzheimer's, as you can see here. Also female, most of them, regardless the dementia type. Most of them white, regardless dementia type again. In my case, I merged all the rest of race ethnicities in one group, because Asian, American, Indian, Hispanic, they had very, very low frequencies. We're talking about hundreds, like couple hundreds. So the problem is when you do this longitudinal analysis, you have probabilities at each age. That's 35 years of follow-up at least. So if you have very low numbers in hundreds, rates are affected by very low number of individuals, and they are not very reliable. So it was better having this group of others with almost 3,000 individuals compared with 116,000 individuals white and 36,000 African Americans. And as you can see also, the mean of hospitalizations was very similar between all groups, all types of dementia. Age at diagnosis the same, and but Alzheimer's, they live more. Mortality is at a higher age, and you will see that in the life expectancy. And also mortality is lower in Alzheimer's. and the one with the highest is mixed dementia, which is the one that is expected to be more severe. So here are the life expectancy. At the left, you have female, and these are male. Life expectancy is at 65 years old. Being Alzheimer's, the one with the highest total life expectancy, but also the highest cognitively healthy life expectancy. And also, as I told you, mixed dementia, which we saw that was one of the highest mortality. Well, here now you can see it as a life expectancy. It has one of the lowest dementia life expectancy, which is the number of years you are expected to live with dementia compared with Alzheimer's. Another important thing here is the huge difference that you always see in life expectancy between female and male. Female always live more, and this is no surprise. Female with Alzheimer's at 65, it's 17.6 years of total life expectancy compared with men, which is almost 2 years less, 50. So that's a lot. But that is always with women and men. They live more, and they live more with dementia also. These are characteristics by race and ethnicity. As I told you, I had to merge all the groups of race and ethnicities except white and African American, just for statistical purposes. Otherwise, the analysis doesn't make sense. So most females in the three groups, African American individuals have a higher prevalence of vascular dementia than whites. And the hospitalizations is also higher in African Americans, and also the age of death is younger, and the mortality is higher. So you will see again all these raw frequencies in the life expectancies, with African Americans having a lower total life expectancy, with lower cognitively healthy life expectancy, and higher dementia life expectancy. So they live less time cognitively healthy, and they live more time with dementia compared to whites. And the difference is big also when you compare mostly the cognitively healthy life expectancy. As you can see here, it is 2.5 years difference. So that's huge. This group, the group of others, it always behaves like in a middle point between white individuals and African Americans in all this in all the analysis I made. This is another way to interpret this kind of analysis. So these are called area charts. So the red area is no dementia. Here in the x-axis, you can see age. What this means, that at 64, everybody, 100% of this cohort of this is white individuals didn't have dementia, right? Then at 65, they start to get diagnosed. And you can see with this dark blue, this is the people that get diagnosed. And with this light blue is the people that starts dying. So you can see as the cohort ages, they start dying, they start having dementia, and the prevalence of dementia is strictly related to the incidence, which is the transition from no dementia to dementia, and the mortality, this is the transition from this state to this state. So that's why this is controlled by those two factors, right? So here, as a reference, I signal what I think is a like staple point in the three groups, which is 84 years old. At 84 years old, white individuals have 20.7% probability of having dementia compared with African Americans, 22.3%, and the other race and ethnicities, 24.3%. And also you can see this big difference in mortality between African Americans, which is 44% versus 38% probability of being dead at 84. So this is another way to visually analyze mortality and these transitions. And yeah, okay. And the next one, okay. The next one was about hospitalizations. So we talked about first all of life expectancy and mortality. Next, hospitalizations. This is the last slide of results. This is where I ended, but as I told you, this is an ongoing work. So I still have a lot to do, but this is hospitalizations by race, ethnicity, and type, dementia type. So here, what you see is that mortality from the previous slides, here it is also translated into in-hospital mortality. So the same results that you see as overall mortality in that population, you see them also in higher rates, translated in higher rates for inpatient mortality. These are this is the total number of hospitalizations, and this is the number of hospitalization. This is your first event, your second event, your third event, right? So 7 events, it covers more than 90% of this total. There was a person with 82 events in this 15-year follow-up. But most of them are in these 7 groups. So these are the rates, and again, the white individuals with Alzheimer's are the ones that show the lowest mortality rates. Those are transition rates from having dementia to and being hospitalized to death. And so at the end, the conclusion is what I think I repeated a lot of times already. African American individuals have a lower cognitively healthy life expectancy and live more time with dementia. They have lower total life expectancy as well. Women have also higher total life expectancy, but also live more time with dementia. And these things are regardless dementia type. Also, probabilities of bad outcomes are lower in white individuals. And the next steps of this model, as I was showing you already transition rates, is doing a Cox proportional hazard model in a reverse Markov chain model. That is, instead of going forward, it's going backwards. Look, like going from death to hospitalization and going from a healthy discharge to the hospitalization event. So the rate in reversal and associating to that transition different coverages that can be the comorbidities, or it can be other sociodemographic variables, or other things like admission sources, where they came from, how they were admitted to the hospital, or how they were discharged. Also, I have the distance from where they live to the hospital. So I want to analyze if there's some kind of disparities. I read an article about despite people coming from the same neighborhood, if they have different race, they have different mortality outcomes. They go to different hospitals, despite living in the same neighborhood. So I want to do an analysis like that, just to back up those kind of results. And yeah, thanks to all the organizers, also from last year workshop, and to Maggie that was helping me, to the rest of the mentors, and also to Brian Downer that is also here listening to me. So yeah, that's all. Thank you.